Ladies and gentlemen, we now welcome Undersecretary Austere Panadero.
Gandang hapon po sa ating lahat. Good afternoon, ladies and gentlemen. And first of all, let me thank the organizers, PHAP, for giving us this opportunity to share some of our thoughts in these conversations on public health, especially at the local level. Although I was here listening to Doc Eric and the other source person and Ernie, I think most of the things I want to cover, they have covered as well. So I decided to cut down on my presentation and probably focus lang on some of the things that I need to emphasize to support the initial ideas as we move forward. Pangalawa, maraming experts na LGUs tayong kasama, so I think it's more prudent to listen to them on how they have done their own. I suppose some of the guys you have helped Ernie are here, no? So they can share also their thoughts on how they have done it at the local level. Let me see. Okay, we're familiar with this, the unbundling of the public health under the local government code. So, sir, good afternoon. So let me just focus on this then. At the central or national level is the function of policy and allied responsibilities, as you can see on the slide. At the local level is healthcare delivery and reporting. But what is interesting, at least from the lens of coordination, efficiency, and equity, is what experts call the fragmentation of health delivery and information. And I refer to the 4 levels at the local level, which you see on the slide there. First, at the provincial level. Second is the city level, which may or may not be under a supervision of the province. Mind you, not all cities are under the supervision of a province. Baka isipin natin lahat ng LGU, sagot ni Gov, hindi. Marami kong hindi. And the third is a municipality, which is under the province. And fourth are the barangays, which either report to the city or to the municipality. The Philippine Human Development Report of 2012-2013 described health devolution arrangements vividly, and I quote, "When health services were devolved to local governments in 1992, the information links were severed between rural health units, or RHUs, and the health offices in the districts and provinces, and between district, provincial offices, and the DOH regional offices and central office. Health services of independent cities, both charter and highly urbanized, those are the cities not covered by the province, function independently of the province. They are geographically located in, and health information is not necessarily shared." End of quote. When information breaks down, as we all know, there is not much local data that can inform national policy. And this is a challenging issue for DOH as much as it is risky for the nation as a whole, especially as we should invest on our collective health and well-being if we are to sustain the country's growth momentum and drive to equitable, sustainable development. And now let me briefly share with you the gains and challenges of local health service delivery based on the data sets that DILG and DOH generated. Ang problema lang nito 2014, but I think there are improvements already over time, but we can use this as baseline as we move forward and as we look at the situation really on the ground. Sabi nga ni Ernie, I think the measurements are there. And in fact, we use that measurement already to check on the situation on the ground. DOH and DILG work on this LGU scorecard. The first that we have diverse behaviors and capacities for local health investment and spending. Provinces and cities and municipalities are expected to fund health services as included in their comprehensive development plans and annual investment programs. We continue to advocate that. In fact, DOH has set a standard. Dapat 15% of their spending ng cities and municipalities and 22% for provinces is on health. But what's the situation in 2014? And I was told also this has improved a little bit over the last 2 years. But however, as we can see on the slide, 35 provinces lang, including component cities and municipalities, meaning all the cities, municipalities in a province, spent at least 15 to 22% of budget for public health. We have 80 provinces at that time. Today, we have 81 provinces. The rest of the LGUs spent lower than the DOH standard. Next, LGU-administered hospital facilities requires improvement. Around 31 provinces reported having overcrowded hospital facility based on bed occupancy. Also, hospitals in 44 provinces are identified to have higher gross death rate than the DOH threshold. More than 10 out of 1,000 admitted patients died per year in these hospital facilities. The quality standard, I understand, is 1%. Third is the state of medical HRD, human resource, and under LGUs. More than half of the province-wide health workers fall short in the number of health practitioners, such as doctors, midwives, and nurses. For instance, 48 provinces have less number of doctors than the DOH standard, which is 1:20,000 population. And only 18 provinces give full implementation of the Magna Carta benefits for health workers. Fourth, on health services performance. There was indeed improvement in province-wide health performance in the following services. TB detection and treatment, access to facility-based deliveries, and access to modern family planning services. On the other hand, around 30% of province-wide networks declined in performance on immunization, malnutrition, availability of skilled health professionals for facility-based deliveries, and ensuring functional community health teams. And finally, health insurance is available, but access to accredited facilities remain a challenge at the local level. As to financial risk protection, 87% of provinces, cities, and municipalities have field health accredited local health facilities, either for outpatient benefit package, maternal care package, or TB detection and treatment services. The challenge, however, is to have these three services available in one health facility and to expand such services to all health facilities being managed by LGUs. Finally, I end my presentation by sharing the views of experts on how to address fragmentation as a result of devolution, which I think some of the speakers already likewise presented. So DOH, and we share and we work with DOH closely on this. We have always advocated for inter-LGU collaboration and partnership building to ensure economies of scale and efficiencies in health coordination. One such approach is the interlocal health zones that look into well-being and vulnerabilities of LGUs along shared ecological and epidemiological factors. In other words, when it comes to public health, politics or territory should not divide us. We should all the more work together. Next, I borrow from the recommendations of the Philippine Human Development Report that to address the inefficiency and short-sightedness brought about by fragmented health systems, mirroring political boundaries and territorial prerogatives from the village up to the provincial levels, we need to shore up the strategic role of the province as the coordinating and supervisory LGU over cities, municipalities, and barangays. I think this was also mentioned by Ernie earlier. The province has a role to play in tightening information linkages among lower-level LGUs and as an overseer of the performance of other LGUs. Of course, this is easier said than done, as we all know it and as we have experienced it, but we are exploring the use of incentives and reinforcement strategies, and which I think Ernie likewise pointed out that to get to the behavior that we desire, we have to have the measurements, the correct measurements, and incentives to make it happen. Just an aside, actually in the Seal of Good Local Governance that we administer, there is a very specific health performance metric that has been included working with the DOH, and that's making sure that each local government has a PhilHealth accredited facility. And that is linked to incentive. By the way, we noticed that provinces, when they get their performance challenge fund, they use it to improve health facilities more than a road construction. So I think that's an indicator that there is an increasing attention being also put to improving health facilities. And finally, LGUs are heterogeneous. They have different situations, capacities, and resources. Equity is a challenge. And if I may quote former Health Secretary Jimmy Galveston, He says poor provinces should get more while rich provinces should give more. I fully agree with Ernie. Those LGUs with less income, be it ERA or local income, should really be assisted. And I think the DOH is moving towards that direction with the putting up of one BHS, Barangay Health Station, and a staff in every barangay. National government na po yun. And the polyclinic model that is being gradually put in place. Those are really needed on the ground to help especially the poorer LGUs. So, between where we are now and the advocacies and directions we wish to bring health policy to, one thing is sure, we've got to make public health system work simply because the public deserves no less. Thank you very much.
Thank you, Undersecretary Austere Panadero. Please remain on stage.